The extraocular muscles are some of the fastest contracting skeletal muscles that we have, and their movement would be precisely controlled by electrical impulses that brain send to them. Recall, for example, in cerebral cortex, we have frontal eye fields. Those neurons send electrical impulses to control the precise movement of these extraocular muscles. And also from superior colliculi of midbrain, we can receive signal, and as a result of the action of these muscles, the eyeballs could move. What we see in this model would be 6 extraocular muscles. These are the muscles that move the actual eyeball. However, I would like to remind you that when we are inside the orbit, we also have another muscle which is missing in this model. That muscle inserts and attaches to the inner side of the upper eyelid, and that muscle is called levator palpebrae superioris. That's the muscle that moves the upper eyelid up superiorly. Basically, that's the muscle that opens the eye. So the action of levator palpebrae superioris is exactly opposite the action of orbicularis oculi muscles. Orbicularis oculi muscles are those secular pattern muscles that we see around the opening of the eye, and those are the ones that close the eye. So in this video, we focus on 6 extraocular muscles, as I mentioned, the ones that actually move the eyeball. 4 of them are called recti muscles. We can see superior rectus, lateral rectus. In the medial part, we have a medial rectus, and below the eyeball, we can locate the inferior rectus. And also we have 2 oblique muscles, the inferior and superior oblique. So we have 4 recti muscles and 2 oblique muscles. The 4 recti muscles originate in tendinous ring. Tendinous ring is found near the apex of the orbit, and is also called annular tendon. This is a ring of fibrous tissue that surrounds the optic nerve. So imagine here we have the origin of the recti muscles, and when you follow each one of them, you see that they move anteriorly and insert on the white portion of the eye, which is called sclera. And one easy way to think about their action is to follow their name. For example, when superior rectus contracts, eyeball moves up. It moves superiorly. We can say that eyeball is elevated. Lateral rectus moves eyeball laterally. We call that abduction of the eye. Medial rectus move eyeball toward the nose medially. We call that adduction of the eyeball. And inferior rectus move eyeball down inferiorly, which we call that depression of the eyeball. So simply when you gaze upward, it means that you're using the contraction of your superior recti muscles to gaze upward. Or if you are gazing downward, mainly you're using the contraction of your inferior recti muscles. And it's also important to know which cranial nerves transmit signal to stimulate these skeletal muscles. For example, when we focus on the recti muscles, we see that superior rectus, medial rectus, and inferior rectus, all 3 of them receive electrical impulses through oculomotor nerve, cranial nerve number 3. However, lateral rectus receive electrical impulses through cranial nerve number 6, which is called abducens. And that should make sense because when lateral rectus contracts, eye is abducted, eyeball moves away from the midline, and that's how we ended up with the name of that nerve. We call it abducens nerve. To find the superior oblique muscle, I go to the medial wall of orbit. Here we have the superior oblique muscle. It originates near the tendinous ring, and as you can see, it passes through the medial wall of the orbit above medial rectus, moving anteriorly, and eventually we end up with this round tendon that superior oblique has. As you see, this round tendon passes through a tiny loop which is called trochlea. Trochlea, this tiny loop, is made of fibrous cartilage. And if you're looking for trochlea, you have to go to the roof of the orbit. On the anterior and medial part, you find trochlea. So the tendon of superior oblique passes through trochlea, then it moves posteriorly and laterally, and eventually somewhere below the superior rectus, it inserts on the posterolateral part of the eyeball attached to the sclera. Superior oblique is the muscle that when it contracts because of its arrangement, the anatomy that I just talked about, it moves eyeball laterally and down. So basically, when this muscle contracts, the eyeball starts moving inferiorly and laterally. And it's important to note that this muscle is stimulated by cranial nerve number 4, which is called trochlear nerve. Hopefully, having trochlea, this fibrous cartilage loop that the tendon of superior oblique passes through, be a good reminder for us that the nerve that stimulates superior oblique is trochlear nerve. Inferior oblique muscle is this muscle that mostly passes through the floor of the orbit. It originates on the maxillary bone, to be more specific, on the anteromedial part of the maxillary bone that forms the floor of the orbit. From here, it moves laterally and posteriorly, and eventually it's going to have another tendon that is attached to the posterolateral part of the eyeball. When inferior oblique muscle contracts, it moves the eyeball lateral and up, basically superiorly and laterally. And inferior oblique is one of those extraocular muscles that would be stimulated by oculomotor nerve, cranial nerve number 3. So as a summary, when we think about the 6 extraocular muscles, 4 of them are stimulated by oculomotor nerve. One would be superior rectus, the other one would be medial rectus, inferior rectus, and inferior oblique. However, we learned that superior oblique is stimulated by trochlear nerve and lateral rectus is stimulated by cranial nerve abducens. Strabismus refers to a condition that eyes do not properly align with each other when looking at an object. That simply means when looking at an object, one of the eyes points at the object and the other one fails to align with the eye that is pointing at the object. This is due to muscle dysfunction and it affects about 2% of children. In general, strabismus could be due to a variety of reasons, including poor attachment of the extraocular muscles to the eyeball, or it could be hereditary. It could be due to trauma that the individual experiences during birth, so birth injuries, problems with brain control center, or infectious diseases could also cause strabismus. When we say we have different types of strabismus, clearly we have different type of treatments depending on the cause of strabismus and the underlying conditions. The treatment plans could vary from the use of glasses, possibly surgery, visual therapy, eye muscle training, and so on. In general, when looking at an object, if one of the eyes is pointing at the object and the other one is pointing at a different direction, that could cause double vision. To avoid double vision, what brain does, it ignores messages sent by the eye that is not pointing at the object. So the ignored eye over time becomes weaker, and that's how we end up with the term lazy eye. In this video, I would like to explain 2 types of strabismus that they are due to lesions that we find on the pathways sending electrical impulses to these extraocular muscles. One is external strabismus. At rest, we see that the eye is tilting laterally. Basically, there is an inability to move eye inferiorly and medially, and this is due to lesion in oculomotor nerve, which would make sense because oculomotor nerve is the one that stimulates the muscles that move eye inferiorly and medially. In internal strabismus, at rest, the eye is tilting medially. Basically, there is an inability to move the eye laterally, and that would be due to lesion on abducens nerve. Hopefully, these 2 examples clarify that it is very important to not only know which part of the brain control the contraction of these extraocular muscles, but also which nerves are used to send electrical impulses to these muscles, and also know about the importance of the attachment of these muscles to the sclera that should be strong. If in any part of these components there is an abnormality, clearly we end up with that abnormal movement of the eye or the failure of one of the eyes to point at the object of interest. I hope you find this helpful.